Good morning and welcome to today's webinar, Behavioral Health in Older Adults. Today's training is being offered by the Behavioral Health Quality Department and Behavioral Health Medical Directors. Today's training will be led by psychiatrist Dr. Tom Allen and licensed clinical professional counselor Amy Danahy. If you have questions for the presenters today, there will be time at the end for questions. Please type your questions in the Q&A box. All right, Amy, take it away.
Good morning, everyone. Thank you for being here and welcome. Today, Dr. Allen and I will be offering a high-level overview of some behavioral health topics in the older adult population. Our learning objectives today will include information that will increase the understanding of behavioral health conditions in the experienced in the older adult population. We'll review some comorbid and behavioral health conditions and substance use in older adults. We'll educate on risk factors, screening tools for behavioral health and substance use. And we'll provide education on interventions and treatment options, including medication considerations and common approaches to care. So we will begin with some statistics and trends of the older adult population, which, according to the World Health Organization, is growing quite quickly. In 2020, there were 1 billion people aged 60 and older worldwide, and this total is expected to increase to 1.4 billion by the year 2030. The number of people aged 80 and older is expected to triple between 2020 and 2050. And this is particularly relevant when we consider lifespan and how human beings are living longer. For example, the average lifespan of a person living in the United States in 2025 is 79.4 years, and that age has consistently trended upwards since the 1960s. Also, according to the World Health Organization, 14% of people ages 60 and older live with a mental health disorder. Chronic health conditions make patients more at risk for mental health disorders. Considering that 80% of older adults have at least one chronic health condition and 50% have two or more, you may encounter a high degree of complexity when treating this population. According to the CDC, depression is the most prevalent mental health condition among older adults, and the risk of depression is exacerbated by one or more health condition. So considering the statistics about chronic health conditions on the previous slide, and the fact that health conditions are often a natural consequence of aging, it makes this particular population particularly vulnerable to depression. And here we have a look at some important considerations and needs of this population concerning behavioral health care. And these are more from the engagement and initial assessment perspective. At top, as always, an important element is cultural considerations. We certainly know the differences in how cultures approach their behavioral, their approach to elderly care, and across cultures, this is going to vary greatly, especially expectations around family involvement and views on behavioral health and medical care. So it's crucial to be mindful of our patient's culture and its role within their particular family system. And then when working with older adults, you may notice that there is some caution in seeking behavioral health care. And because of that, mental health disorders that existed over one's lifespan may have never been treated. Symptoms may be dismissed or minimized. People in this population may not understand the value or how to access, or they may worry about what needing and seeking this type of treatment means to them and about them. So as a result, without any prior history, mental health conditions or substance use symptoms can appear as a response to medical conditions or life stressors. So there's room for misdiagnoses with this population. Another important consideration is to be aware of our own biases. our interactions with our parents or older adults in our lives as clinicians will certainly inform our outlook and how we treat older adult patients. And just like with cultural consideration, it's important to be aware of our own biases to avoid extrapolating. And it's also relevant to consider how cognitive decline may appear as a mental health condition or vice versa. So, normalize, validate, educate to increase understanding and encouragement um, around engaging in treatment, and then keep those cultural considerations at the forefront to increase your own understanding about how your patient navigates the world in treatment. So let's explore the socio-emotional risk factors and screening tools. We've talked a bit about how chronic conditions can exacerbate the risk of depression in older adults. And these are a few risks and challenges you might encounter when treating older adults as the provider. You may see your patient or their caregiver even minimizing symptoms, and this could be attributed to a number of things. It could be low health literacy, denial, shame. They may be scared about the consequences of sharing. I've seen this in my own practice around patients with diagnoses of Alzheimer's or alcohol use disorder. There's fear, there's denial, there's worry about what comes next. And the symptom may be apparent, but the patient and the family may not be ready to face what's next, that pre-contemplative stage. There could be caution around accessing care even when there is a need. As mentioned earlier, older adults may have negative perceptions about behavioral health care and what seeking it out and receiving treatment means about them. There's the cultural norm. Being aware of those cultural considerations is of great importance, and how a patient may or may not be receptive to treatment as a result. Some risk factors to be mindful of. If your patient is socially isolated or has a history of depression or sensory or mobility loss, any sleep disturbances or medication side effects. So if you suspect and your patient is for whatever reason not able to articulate what's going on, these are a few things that maybe warrant a closer look and further assessment to really tease out what's happening. Okay. Some more things to consider. Is it depression? Is it grief? Is it adjustment disorder? There's a lot of adjustment that occurs within the older adult population, and the following are just a few. The end of career. Older adults generally retire by choice, or they can no longer perform the functions of their career and they're forced to retire. So now what occupied and stimulated their minds and contributed to a really consistent routine is no longer available to them. And that could be a huge destabilizing loss. There's a loss of independence, either by choice or by need. Perhaps they have to move home. They're adjusting to their new surroundings, new people, a new routine. Maybe they can no longer drive. Maybe they're experiencing limited physical mobility. There's also relational and social changes. If our patients are parents, how do those relationships with their children look, their adult children? Have they cultivated a relationship with their adult children that is healthy and flexible, or is it a source of discord? And do you, as a provider, do you notice a role reversal happening? Many older adults experience the loss of a spouse or their partner. That's devastating on its own, but compounded if the patient neglected to nurture and maintain friendships and a support system, or if they have a complex relationship with their adult children. This is the pipeline to the social isolation that we discussed, which is a big indicator of depression in older adults. And death. Older adults naturally start to contemplate their own mortality, and they often start to see their peers die. And when you consider what we know in our work as the major life stressors, the big ones, so career change, new job, retirement, marriage, divorce, moving home, death of a loved one, For an older adult, all of these things can occur in very quick succession, which could be extremely destabilizing and understandably lead to depression and anxiety. Next slide, please. I want to call out the final stage of Erikson's psychosocial development. Erik Erikson was a psychoanalyst who developed a theory of human development with 8 stages over one's lifespan. And the final stage is integrity versus despair. And this usually occurs in later in life, like late 60s maybe, where an individual reflects on their life. And the very basic thinking is that if they're able to experience integrity, if they see themselves having led a successful life, or conversely despair if they feel like their life was unproductive, they did not accomplish their goals, etc. So this period of reflection and meaning making can really open the patient up to feelings of regret and hopelessness and depression. So there's a ton that an individual in this population can experience or attempt to reconcile during this stage of life. And if the individual does not have the tools to navigate these changes, or if there is an untreated behavioral health disorder, this can create a perfect storm of dysregulation. And yet, as providers, it may be very easy for us to dismiss a lot of these things as part of the aging experience. It's natural to retire. Of course, you're downsizing. Sure, your friends will pass away. And certainly our own experience, as mentioned earlier, with parents and people in our lives who are part of the older adult population will inform how we perceive and how we treat. So it's just important to be mindful of that. Okay, next slide, please. Here we have a look at some screening tools for our older adult population as it concerns depression. So depending on their tolerance, you have a couple of options. The Geriatric Depression Scale, or the GDS-5, there's a short and a long version of this assessment. So it's either 15 or 30 yes or no questions as the assessment. There's a Depression in Old Age Scale, or the DIAS-4. This is a short 4-item screening tool to assess depression symptoms in older adults. And this looks at mood, energy, pleasure, and rumination. And then, of course, clinical interview with the patient, and even better if you can interview a caregiver or an adult child or a previous provider. And you can get personal and familial history. And this can offer some really rich insights and close a lot of gaps than just interviewing the patient by themselves. Okay, at this point, I will pass it off to Dr. Allen.
Thank you, Amy. Good morning, everyone. So now we're going to shift gears. Instead of talking about depression, we're going to talk about conditions that can cause agitation in older adults. So specifically bipolar disorder, psychotic disorders, and other conditions. And before we get into the risk factors on the slide, I just want to sort of define what bipolar disorder and psychotic disorders are. So first, bipolar disorder, as we know, it's a cyclical mood disorder. So alternating between lows of depression and highs of a mania or a hypomania, which we'll define. There are 2 types. There's the more severe type, which is bipolar disorder type 1, which is characterized by having a manic episode. And that's at least a week of expansive, irritable, euphoric mood, plus at least 3 other symptoms like racing thoughts, speaking fast, not needing to sleep. It's sort of a revved up state. And this causes significant interference with someone's functioning. With bipolar disorder type 1, somebody can go in and out of mania, and depression is not necessarily required. However, for bipolar disorder type 2, which is a milder form, instead of having the week-long mania, the period is only 4 days, and that's called hypomania. And that's same symptoms of expansive mood plus activation as what we see in mania, but it's more attenuated, and it doesn't have the functional impairment that we see in mania. And unlike bipolar disorder type 1, bipolar disorder type 2 does require the presence of a major depressive episode. So we'll see kind of cyclical mood disorders that typically begin in adolescence, young adulthood, but can and persist into adulthood, older adulthood, but it can also start in older adulthood as well. Um, a psychosis is really a symptom. It's not a diagnosis as such. It's a symptom that could be a result of multiple diagnoses. So it's essentially being out of touch with reality. So hearing things that aren't there, seeing things that aren't there, believing things that are not true, disorganized thought process, etc. Um, psychosis can be caused by schizophrenia, for example. It can be caused by medical conditions like a delirium, which we'll get to. It can be caused by dementia, which we'll get to as well, or other drugs of abuse or medications like steroids. Other risk factors include family history. So, for example, bipolar disorder, 80% of people with a first degree relative with bipolar will also are at risk for having this condition. And same with schizophrenia, it also runs in families. Environmental factors, certainly things like external stressors, sleep deprivation, those can exacerbate underlying illnesses like these, trauma history, as well as substance use. Next slide, please. So, what is the differential diagnosis of agitation? So, we first want to consider personal and family history. What runs in one's family? Does someone have Huntington's disease, Parkinson's disease, dementia? What could possibly account for this? Does someone have psychiatric history in their family? Personal history as well. Also look at conditions with similar presentations. So some of the presentations that exist throughout adulthood or throughout one's life and persist into older adulthood. So developmental disabilities maybe, or intellectual impairment, maybe a personality disorder is kind of is persisting as well. And then of course, dementia and Alzheimer's disease, we'll get to that in a subsequent slide. But when we look at kind of the differential of agitation, we want to see, is this something that's more organic, something more medical, or is it more like an adjustment disorder? Is it related to an acute stressor in one's life? When we look at organic, it could be brain injury, brain trauma, seizure disorder, anything that's intracranial that could explain some of these behaviors. Also, it could be delirium, which is defined as an acute mental status change that typically has problems with awareness or attention, along with other cognitive complaints like disorientation, for example. And it's caused by an underlying medical condition. So it could be dehydration, it could be infection, hypoxia, but it could also be caused by substances or medication changes. So in the elderly, since medications are often changed, we often see polypharmacy, that could be a high risk for someone who's older. And then the treatment of delirium is typically treating the underlying medical condition or removing that substance that could have caused it. Also, we want to look at possible physical causes of agitation. Is somebody in pain? Are they constipated? Something if they can't express what they're feeling. And then, in cognitive decline, I've seen this, or we probably have seen this before, where we have an older adult with dementia who misplaces something, say their keys, and they believe that it was stolen, and they're blaming other people, and they get agitated. So there might be this memory impairment that causes a kind of a misperception or misunderstanding of what's going on. Next slide, please. So what are some screening tools to evaluate causes of agitation? So once we've ruled out medical causes, if we want to look at possible psychiatric causes, the mood disorder, these are all, by the way, these are valid and reliable and in the public domain. Some might require special permission depending on how they're used, but they're generally available. So the mood disorder questionnaire is a relatively quick 13-item self-report to assess for symptoms of bipolar. Bipolar inventory of symptom scale is a little bit longer. It's 44 questions. It's clinician administered. also looking for symptoms of bipolar. There's the functional assessment short test, which is a clinician report, 24 questions, getting at functional impairment related to bipolar. There's the brief psychiatric rating scale, which looks at symptoms of psychosis. So things like hostility, suspiciousness, hallucinations. It's an 18-item clinician reported questionnaire. And then you have the Pittsburgh Agitation Scale, which is a 4-item clinician observed instrument used to assess agitation in people with dementia. But also, in evaluating agitation in older adults, we certainly want to do a physical health screening. So, neurological exam, physical exam, labs, for example. So things that are kind of top of the list, especially with acute mental status changes, are like a CBC to see if there's an underlying infection or anemia. We want to look at chemistry panel for electrolyte abnormalities, liver kidney impairment, thyroid studies, to rule out things like hypo or hyperthyroidism. Sometimes syphilis testing is helpful in someone with risk factors to look for something like neurosyphilis. Neuroimaging can be helpful if someone has a history of brain injury or intracranial lesions, for example, bleeds, or if there's focal signs and symptoms on a neurological exam, or acute mental status changes. And then things that we know about, urine toxicology screen, serum alcohol, and then finally, sometimes EEG is ordered if there's a concern about a seizure disorder. So, the differential is very wide, and it's really directed by what are some of the clues you might get either on family history, personal history, physical exam, or clinical interview. And then just to note, when we talked about labs, if we have somebody who has schizophrenia or bipolar and they're on an antipsychotic, it could either be a typical antipsychotic or atypical. We recommend checking the blood sugars, hemoglobin A1C, and the lipid panel at least annually to rule out things like diabetes, high cholesterol, things that can contribute to cardiovascular disease. Because as we know, these medications increase the risk for those. Next slide. So what are the different types of dementia? There are different cognitive conditions in the elderly, and some of these could be diagnosable as dementia. So as we know, as we get older, memory impairment can be normal. It can get worse as we get older. We forget people's names, where we put things, slower time to remember things. However, if the cognitive impairment is more extreme than what would normally be anticipated for someone's age, or if it's causing significant functional abnormalities, problems with their basic ADLs or IADLs like paying bills, etc., then you want to do a deeper dive and see if something else like dementia might be going on. So dementia is an acquired condition that is a decline in both cognition and function. And according to the DSM, it's also called a major neurocognitive disorder. The cognitive dysfunction could be in the area of learning and memory, language, concentration, executive dysfunction, social cognition, and perceptual motor skills. So a lot of different areas of dysfunction cognitively with someone with dementia. The most common causes are neurodegenerative, and the most common neurodegenerative cause is Alzheimer's disease, which accounts for about 60 to 80% of all forms of dementia. The other types are frontotemporal dementia. It's a typo here. It's not frontal lobe dementia. It should be frontal temporal dementia. That typically involves behavioral changes, so personality changes, inappropriate behaviors, along with the cognitive decline. There's Lewy body dementia, which has motor Parkinsonism associated with the cognitive decline. So things like bradykinesia, tremors, rigidity, and postural instability. And then we have, it's not on here, but vascular dementia is another one. It's somebody with vascular risk factors, diabetes, hypertension, or atherosclerotic disease. If they've had history of strokes or current strokes, that all can explain what's more of a stepwise progression in cognitive decline. So particularly things like executive functioning and processing speed. Um, and then in addition to cognitive decline, dementia, as we know, can cause changes in mood, behavior, and social interactions. So what are some of the risk factors? Definitely physical health. If we look at high blood pressure, diabetes, obesity, high risk for things, especially like vascular dementia, diabetes, smoking, excessive alcohol consumption. Those can be pro-inflammatory or directly toxic to the brain, and that can cause damage and lead to dementia. Head injury, of course, can lead to it. And then family history. So some dementias like Alzheimer's and frontotemporal dementia do run in families, especially if the dementia presents before age 65. So it's more of an early onset. And those who have, for Alzheimer's dementia, those who have a first degree relative with Alzheimer's are at higher risk of developing it themselves. Next slide. And what are some screening tests and evaluation for dementia? So there's the mini mental state exam. Many of us know this. It's a quick 11-question assessment for cognitive skills. So it covers orientation, attention, memory, language, and visual spatial skills. And then there's the MoCA, or the Montreal Cognitive Assessment, which is very similar. It's 30 points and administered in about 10 minutes. And what's good about these is they can be done at the bedside. They're an objective measure of one's cognition. Usually an objective measure doesn't necessarily require something as exhaustive as neuropsychological testing, though that can be done if the results are ambiguous or not entirely clear. Neuropsych testing could be helpful, but this can be sufficient if you just want an objective measure of one's cognition. And then you also want to do, obviously, a clinical interview and caregiver responses. Amy said this previously, but often we want to interview family members because people with dementia often are unaware of their symptoms. So we need that third person perspective, definitely family and individual history to give us an idea of what might be going on, especially for the heritable conditions. And then coordinator and consultation with providers. So, obviously we want to rule out medical conditions, look at medications that the person's on. This might require coordination with specialists, primary care, behavioral health, so that we're collecting all of the data that could help us know what's going on. Next slide, please. And I will pass it back to Amy.
So we will pivot now and explore substance use in our older adult population. We have some statistics from the Substance Abuse and Mental Health Services Administration, or SAMHSA. Substance use disorders can go unrecognized and untreated, and symptoms may be mistaken for normal age-related changes concerning memory, disorientation, motor skills, sleep patterns, mood, etc. Illicit drug use is more common amongst current older adults than previous generations of older adults, and this is expected to continue and increase. Alcohol and prescription drugs are the substances most frequently misused, and I want to note, cannabis is more accessible in a way that previously it's never been this accessible, and it can be used medicinally. So it'll be very interesting to see what role cannabis plays with this and future generations of older adults. Older adults may metabolize alcohol differently and be more sensitive to its effects. They may be at more risk of fall and injury due to being more likely to take medications that interact negatively with alcohol. There are barriers that make this population less likely to seek treatment. Again, social and cultural norms, values, false ageist beliefs can all contribute. This population may minimize, deny, hide substance use related problems from others. And other barriers include negative attitudes among providers or family, denial, lack of knowledge about substance use, and lack of awareness of available or effective treatment. Slide, please. Here is a list of common risk factors that that may make your patient more vulnerable to substance use disorders. As discussed earlier, all of those potential adjustments, retirement, grief, loss, economic stress, change in living environment, past trauma, comorbid mental health conditions, family histories, and social isolation are all risk factors. And certainly a previous history of substance use could be a factor as well. So you may see relapse after a very extended period of sobriety. Okay, and next slide, please. And here we have some considerations for older adults and substance use. There are diagnostic considerations as it pertains to older adults meeting criteria for substance use disorders and essentially more to rule out. Patients with chronic pain, sleep issues, history of depression, and anxiety may use medication to treat those conditions, which is good, but it can also get tricky. They should take those medications to manage those symptoms, but are they taking these medications as prescribed? Worsening acid reflux and sleep problems could be indicators of substance use if you believe your patient is minimizing use. And then similar to what we discussed earlier, substance use among older adults increase risk of injury and fall, and can also increase the risk of cognitive impairment, heart disease. It can mess with glucose levels, hepatitis, cirrhosis, and mental health disorders. Okay, and next slide, please. All right, here we have a list of, or a look at our screening tools that we could use for older adult patients as it pertains to alcohol use. We have the Alcohol Use Disorders Identification Test, or the audit, and this is a quick 10-item screening tool that's used to identify risky alcohol use and alcohol use disorders in adults 65 plus. We also have the Alcohol Smoking Substance Involvement Screening Test, or the ASSIST. And this is a tool that is used with early identification of substance-related health risks and disorders. And then we have the CAGE AID, and this is a brief standardized questionnaire that focuses on alcohol use, which asks the subject questions about their reactions to their own use. So do you have feelings of guilt when you think back on your use of substances, or are you annoyed when others ask you about your use? So these are assessment tools, not diagnostic tools, but hopefully they can offer some help in getting these conversations started. And like Dr. Allen mentioned, these tools are all part of the public domain as of right now. Okay. And Dr. Allen.
Thanks, Amy. All right, so now we're going to talk about interventions and treatment options. Next slide, please. So first, we're going to look at psychotherapy options, and these can all be either individual or group. The first type is cognitive behavioral therapy, which many of you know helps people engage in meaningful activities or to avoid behaviors that could be contributing to their depression. It also helps them to challenge cognitive distortions, which might contribute to depressive symptoms as well. There's interpersonal psychotherapy, and this is based on the theory that depression develops in a social context. So it addresses four components like grief, interpersonal disputes, role transitions, and interpersonal effectiveness. So helping people maybe become more assertive in the context of others. And then there's group life review or reminiscence therapy. This is a form of psychotherapy that encourages individuals to recall and discuss past experiences, memories, and events. And it helps improve their well-being, their cognitive function, and their emotional regulation just by virtue of revisiting these significant moments in their lives. Some psychopharmacological interventions will be really brief and high level. So for depression, the ones we typically use are SSRIs and SNRIs. Um, those are the SSRIs are things like citalopram or sertraline. SNRIs could be like duloxetine or venlafaxine. Those are effective and pretty safe in older adults. And you'll hear this theme come up, side effects to avoid, and we want to look at kind of the mechanism of action. So we want to avoid medications that have significant anticholinergic properties. So those are medicines like, oxybutynin that helps treat muscle or bladder spasms, Benadryl. Those can cause confusion, dry mouth, constipation. So those can be problematic in the elderly. We also want to avoid medications that have a lot of antihistamine effect. So again, like Benadryl can cause a lot of sedation. And then finally, medications that block alpha-2 receptors. So these are medications that can lead to a low blood pressure and cause orthostatic hypotension and falls. So I'm bringing that up because, like for the antidepressant category, there are tricyclic antidepressants, and those we want to be cautious of because they tend to have all three of those potential side effects, those receptor activity that can lead to those side effects. And then if we look at bipolar disorder, typically the mood stabilizers, valproate, lithium, are generally effective and safe in the elderly. One thing to be cautious of because of lower or impaired kidney function or lower time to break down the medications, dehydration, people are at risk for toxicity. So you want to make sure you're checking levels pretty regularly. And then finally, for psychosis, the antipsychotics can be safe and effective in the elderly when used to treat psychotic disorders or bipolar disorders. As we know, there's a black box warning for both typical and atypical antipsychotics for use in people with dementia and treating behavioral symptoms. And so it's not generally recommended to use these medications for that. As an alternative, non-pharmacological interventions, behavioral interventions are usually more effective than antipsychotics and safer. And the reason they're not recommended is studies have shown that these can increase mortality due to the cerebrovascular, cardiovascular consequences in this population. So the risks might outweigh the benefits. But when we look at antipsychotics for psychotic disorder, bipolar disorder, there are ones that are safer than others. When we look at antipsychotics, there are generally two categories. There's the first generation or typical antipsychotics, and then there's the second generation or atypical antipsychotics. The first generation, the one that can be particularly problematic is the high potency, those like haloperidol. Those are at high risk for causing tardive dyskinesia or movement disorders in the elderly. There's also the low potency first generation antipsychotics like chlorpromazine. Those can have a lot of the anticholinergic, antihistamine, and anti-alpha activity that could cause falls, confusion, etc. And then there's the second generation or the atypical antipsychotics that we know about, like olanzapine, quetiapine. Those have higher risks for things like increased blood sugar, metabolic factors, and high cholesterol, and lead to cardiovascular disease. So those are all these medications carry risks, but some are more likely want to avoid because they have higher risks than others. And then if we look at treatment for dementia, we have the anticholinesterase medications that like donepezil, or the NMDA receptor blockers like memantine. Those are generally safe and effective in slowing cognitive decline in people with mild to moderate dementia. And then generally, when we look at psychotropic medications, they're generally more effective when combined with psychotherapy. And then other considerations, referrals to community resources, socialization, as Amy said, is so important. So things like, adult day services can be really helpful. Just getting people out and stimulation of day-to-day activities, but also caregiver alignment. As we said, a lot of the interventions for people with dementia and behavioral disturbances are non-pharmacological. So really working with the caregiver to teach them tools for managing these behaviors at home. So things like having a really good sleep hygiene, bright lights during the day, darkness at night to try to regulate that, orienting the patient to their surroundings, making sure they know where they are, what the date is, avoiding sudden changes, and then having certain sensory practices that sort of ground them, like massage, aromatherapy. And then finally, exercise can be helpful as well. But before we go on, I just want to address caregiver burnout is significantly important to consider as well. The caregivers are doing so much work to help their loved ones, and we have to be mindful of the toll this takes on them or can take on them. So look at things like counseling for them, peer support, and also things like respite or paid caregivers. Next slide. So what are some treatment concerns in providing medications for this population? A lot of this Amy already said, but side effects, sedation, dry mouth, constipation, some of those side effects we mentioned in some of the medications before. Falls, certainly if there's excessive sedation or lightheadedness, that can contribute to that. Toxicity, there's decreased renal activity, decreased elimination of drugs, leading to potentially toxic levels in the blood. So if you're seeing acute mental status changes, you might want to, if there is a ability to check blood levels, that might be helpful. And then also polypharmacy. Often older adults continue to there's a cascade effect or kind of a layering on of multiple medications depending on providers or if they go in and out of the hospital. So a lot of this needs to be looked at and simplified as much as possible to avoid drug interactions. And then looking at psychiatric medications, sort of the rule of thumb is, if you find a medicine that's safe, you really want to start at a pretty low dose, maybe even a little bit lower than what's typically recommended for adults, and then go up pretty slowly so that you can monitor these effects over time. Next slide. And here's some tools for reducing inappropriate prescribing of psychotropic medications in older adults, and actually of medications in general in older adults. So there's the Stop and Start toolkit. So the Stop is the screening tool of older person's prescription. This identifies medications that are recommended to stop in older adults. And then there's the Start, which is the screening tool to alert to right treatment. This is a tool to identify medications that are recommended to start or are relatively safe to use in older adults. And these are based on disease diagnoses, and disease categories, or also body systems. So you look at GI medications, respiratory, cardiovascular, etc. And then we have the Beers criteria, which many of you know about. It was developed many years ago by the American Geriatric Society. It's updated every 3 years, but it lists medications to be avoided or used with caution. It also categorizes medications based on potential risks, such as drug-drug interactions, increased risk of falls or cognitive impairment, and it provides recommendations for alternative medications or strategies when the potentially inappropriate medications are unavoidable. So it really works with you to try to help guide you on how to prescribe or how not to prescribe certain medications. And I will turn it back to you, Amy.
Thank you. So we'll spend some time talking about the coordination of care for the older adult population, but also very relevant to this population, as Dr. Allen mentioned, is their caregivers. You'll see this more often than you would in the middle-aged or young adult population, that there are others that are invested in your patient's care and attending appointments and taking notes, and they may be the spouse or the adult child or a caregiver. You'll probably see this less so in psychotherapy beyond the initial intake, but think more like primary care. So we wanted to just share some thoughts around the coordination of care, not only for your patient, but also if you encounter a caregiver who needs support that you're not able to provide. It's definitely advisable to collaborate with the patient's care team to the extent that you're able and work within scope, knowing when to refer out to the appropriate level of care. So like, PCP to neurologist when it's time to step up. It's very wise to be familiar with resources available in your community should those questions arise. The Department on Aging, any senior services from your local city or village township, any care coordination or case management programs, your local Medicaid office. These can all be invaluable in helping families understand what's next and increasing financial literacy. There's Al-Anon or Narcanon if there's substance use, and understanding the different levels of care um, between like independent, assisted, memory care, etc. And then, as Dr. Allen mentioned, being aware of what respite options are available or caregiver support groups in your community. Hopefully, our adult population will have their affairs in order through their advanced directives, power of attorneys, or medical power of attorneys, etc. And you don't have to be an expert on any of this. Just have a general awareness of resources in your area so you can tap into them if the need arises. Okay, next slide, please. And here we have a reminder about the importance of follow-up care. So while this is a HEDIS measure, especially following a behavioral health inpatient level of care or substance use inpatient level of care, seeing patients within that first week to 30 days after discharge really is the optimal time for stabilization in the community and securing linkage. So follow-up appointments can prevent future admissions and then ultimately improve health outcomes for patients by ensuring they're securely connected to you as the outpatient provider. These appointments can be with a therapist, a psychiatrist, nurse practitioner, APN for med management, symptom management, or coping skill building. And certainly following up with a primary care physician is also very appropriate. Next slide, please. Also concerning follow-up care, we have some tips about how to engage patients who may appear resistant to consistent treatment. We encourage you to refer out to your behavioral health colleagues when appropriate and to collaborate with other providers. You may receive a phone call from a behavioral health care coordinator from Blue Cross, maybe trying to connect with you about your patients. And we do encourage that, acknowledging your severe time constraints with your patient load. That collaboration is really to support positive outcomes for the member and help connect dots. And it's an opportunity to share resources too. Okay, next slide, please. And finally, we have some resources for you as the provider to share with your patients if you would like. These are 4 short patient-focused videos about relevant behavioral health topics. You are free to share these QR codes and links. You can run them in your waiting rooms. You can include them in your discharge paperwork, whatever you like. And all of these are available with Spanish captions as well. And this concludes our presentation. Thank you so much for your time.
Thanks, Amy and Dr. Allen. We're going to get into some questions, but I do just want to make a quick note for all of you attending today. Thank you for making time this morning. Just know 24 hours after today's webinar, you will receive an email link to complete both an evaluation and attestation. You'll have to complete both in order to receive your CME and CEU credit. So just wanted to put that out there. The slide deck will also be available on the website that you registered. But let's jump into some of those questions that were popping up in the chat. So Dr. Allen or Amy, you can decide who wants to take each. But the first question I saw, is there any information you can provide about clients or patients who decline tests? What are some tips on supporting families to get these patients into the sessions to be able to conduct the assessments?
Yeah, that's a good question. I think, in working with patients, certainly in probably doing this already, but really exploring what they understand about the test, what they are concerned about, what the tests might mean. Maybe somebody they know had a similar test and they had a negative experience. So kind of understanding what their understanding is, what their impressions are, what their expectations are, their fears. And then maybe once you get a better view of that, then you might be able to sort of talk about how to address those concerns you know in a way to try to get the test completed. But I think like anything else, just um, maybe even something like motivational interviewing. Anybody who's resistant to something, we want to find out really what's important to them, because people are generally motivated to do things that are important to them. So really find out what that is. Are do they are they afraid of having a particular medical diagnosis? Could that potentially get in the way of some of their goals or their dreams? Or do they want to know about what they have? Because if they treat it, then they may be more likely to be able to do some of those goals and dreams. So I think kind of exploring what's meaningful to them, what they want, and maybe let them um, maybe ultimately they might make an argument for getting these tests if they see that it really can lead them toward reaching some of their goals. Um, so I don't know, Amy, if you have anything else to add.
No, I agree. I agree. I think working with that resistance, seeing trying to tease out the underlying cause of that resistance, and then just really being patient,
Mm.
hope that something will shift and they'll be more agreeable. But that's tough. That's a great question. That is a tough and common uh, challenge we all face.
Great, thank you both. So another question, are there any recommended cognitive screening tools for non-English speakers?
Mm. Oh, yikes, that's a good question. I don't know. I wonder if some of these versions have a Spanish version. I think that would be the first thing to check. Especially the ones in the public domain. Um, I think that would be the first thing to check is to see if there's a Spanish version of the ones we already talked about. Um, but yeah, that's all I can think of now.
I think it would largely depend on the provider administering the
That's
assessment
true.
too. I would imagine that they would be able to communicate in the language of their patient, so that might be a workaround.
Yeah, that's a good point. And thank you, Amy. So some of the tests are, patient completed, and some of them are physician or provider completed. So the ones that are provider completed, they might be able to either translate it themselves or have someone else translate it for them.
Another question I saw in there is, could excessive use of alcohol in adults over the age of 50 lead to psychosis at some point, especially if there has been long-term use, say 30 plus years?
Yeah, the short answer is yes. So definitely alcohol use is a risk factor for the development of psychosis or the exacerbation of an underlying psychotic disorder. How it could be particularly problematic is it could lead to, alcohol dementia, for example, which could also have psychotic features, or it could lead to delirium, acute intoxication or withdrawal, with the development of things like delirium tremens and things like that, where people are hallucinating. So in the acute stage, you can have psychosis, but also in the chronic stage, especially if it's developing more of um, a dementia sort of picture, you can get that as well.
Really? And can you speak to any considerations for primary care physicians assessing and treating dementia for older patients who may not see a neurologist or specialist?
That's a really good question because, as we know, I mean, as Amy said, the adult population is getting older. We're seeing a higher prevalence of dementia nationwide. We don't have enough specialists really to treat this condition, given the need. And a lot of primary care providers are doing the bulk of the treatment. Um, so I think, definitely the when they're evaluating somebody for dementia, in addition to the interview with the family, but also with the patient, doing the physical exam. You want to do some of those bedside screening tools, like the MoCA or the Mini Mental, just to get an objective assessment um, of their cognitive abilities, and then look at the functional impairments. But we want to really compare this to baseline. Is there a significant change? Um, and then once we sort of get those clinical factors figured out, then we want to make sure we rule out other possible causes. So whether it's medications or general medical conditions, psychiatric conditions, and then if we think it's dementia, then we can, go down the road of different, continued evaluation to see what type it is, or look at different treatment options. But, a lot of this can be done in a primary care setting, and it might require consultation with a specialist, but we're seeing, that there is an increased need within primary care.
Thanks, Dr. Allen. I know we had a few questions in there. If there's any suggestions on um, sites for accessing some of the screenings that were discussed today, as well as good sources of information for finding respite resources for patients and caregivers.
I don't know, Amy, if you know that one.
Sure, I could try. So the tools that we shared largely are considered public domain. And so the best places to try to access those, look at the CDC, look at the SAMHSA, look at the Department of Education. I will say they're public domain because of federal backing. So they were available to all of us on the public domain, but due to changes in federal efficiency, maybe they might be harder to find. So I would start there: CDC, SAMHSA, Department of Education, Department of Public Health. In terms of finding respite in your community, I would check the Department of Aging. Usually all counties have a Department on Aging. If, depending on where you live, look at like village township, city townships. The city of Chicago will have their own division. There are also, not always applicable, but funeral homes are a really good resource for grief and individual and support and referral sources. That should get you started. I hate to like default to say just Google it, see what's local to you, but really that is what's local to you. There are also a lot of, depending on how internet savvy our patients are, there are some really excellent online resources, community support groups around like message boards. So that might be an option as well.
And one more thing to add, some of the hospice and palliative agencies too have resources for paid caregivers, because it's a challenge encountered within that population as well. So that might be another resource.
Thank you both very much. I did just want to address a couple things before we come to a close. First, thank you all for attending today for the presentation, Dr. Allen and Amy. So for all the attendees, you will receive an email link 24 hours after the end of today's training to complete both an evaluation and the attestation in order to receive CEME and CEU credit. The recording of today's presentation will also be sent out to all attendees, and you can receive a copy of today's slide deck by going to the website that you registered, the same place where you'll complete your evaluation and attestation. You can download a copy of that deck at that same site. But thank you all again for attending today, and we hope that you have a great Monday.
Thank you, everyone.
Thank you.